Hi, my name is Erin, and I'm going to be teaching you the postpartum assessment today. So before you begin, you're going to walk in the room, provide privacy, and perform hand hygiene. You're going to have all your supplies gathered in the room, so you're going to have a stethoscope, a reflex hammer, and some gloves in your size. And then you're going to introduce yourself to your patient. So, hi, my name is Erin, and I'll be your nurse today. We're going to be performing a postpartum assessment on you, so just checking you out head to toe to make sure that everything's working right after delivery. Now you're going to identify your patient. So can you state your name and date of birth for me? And she's going to tell me, and I'm going to check it against her band that she has on her arm. And do you have any allergies? And I'd also check that against her band if she had one. At this time, I would make sure that vitals have been taken and are all within normal limits. And I would raise the bed to a working height if need be. Now we're going to start with some general questions. So how are you feeling today? And how did you sleep last night? It's normal for your patient to have not slept very well or to have had some night sweats. Also, if she's not feeling okay, that's also kind of normal finding. Now you're going to ask her if she's in any pain, and you're going to take her through the PQRSTU format. So P stands for palliative or provoking factors, so anything that makes her pain better or worse. Q stands for the quality of your pain, so is it dull, is it sharp, is it aching? R stands for the region, so where is your pain and if it radiates or spreads anywhere else. S is severity, so rate your pain for me on a scale of 0 to 10, 10 being the worst pain you've ever felt. T is time, so when did your pain start? Is it constant or is it intermittent? And U is how does it affect you? Is it affecting her vital signs? Is she guarding? Is she grimacing? Is it affecting her daily activities or anything like that? And also you're going to want to ask her if she's seeing any floaters or spots before her eyes or having any blurry vision. Also if she's experiencing any headaches, which you don't want to see any of those factors because those could be signs of preeclampsia. Now we're going to go on to the heart and lungs. So I'm going to grab my stethoscope and I'm going to listen to the heart sounds using the ape to man format. So the A in ape stands for aortic. And this is at the second right intercostal space, and this is at the right sternal border. Then we're going to go to the left intercostal space on the left sternal border, and this would be the pulmonic. Then we're going to go to Erb's point, which is at the third left intercostal space at the left sternal border. And then we're going to the tricuspid valve, which is at the fourth left intercostal space, left lower sternal border. And the mitral valve, you might have to lift the breast for this one, is at the fifth left intercostal space, mid-clavicular line. When you're listening to these heart sounds, you want to listen and make sure that you're hearing S1 and S2 clearly. You want to note if there are any swishing sounds or signs of a murmur. And now we're going to listen to our lungs. So when we listen to our lungs, we do that in a Z pattern formation. There are 3 lobes in the right and 2 lobes in the left. And the best way to remember that is when you draw an R, it takes 3 strokes, and when you draw an L, it takes 2 strokes. So we're starting in the right upper lobe. We're going to listen for 1 full inhale and exhale. Then the left upper lobe, the right middle lobe, the right lower lobe. Again, you may have to lift the breast to get to this, and the left lower lobe. And when you're listening to the lung sounds, you just want to make sure that they're clear, that there's no adventitious breath sounds, that there's no crackles or wheezes or anything like that. Next, we're going to go on to the breast examination. So we're going to ask our patient, are you breastfeeding? And if she is, you want to ask her if she's wearing a form-fitting wireless bra. And if she's not, she still needs to be wearing a wireless bra, and it should be tight-fitting. And whether or not she is breastfeeding, just ask her if she feels her breasts getting heavy, if they're tender at all, and all of this would be normal signs. Now you're going to palpate her breasts, so you're just going to feel, they may be tender, and that's a normal finding again, but you're going to feel and make sure that they're soft, and you're going to let her know that you're going to expose her at this point so that you can check your breasts. You're going to note that the nipples are clean and intact bilaterally, so on both sides. You're going to make sure that there's no chapping or cracked nipples, and you're going to ask her if she's seen any colostrum being expressed, which is that yellowish color discharge that comes from the nipples for the first couple days. Now we're going to move on to the upper extremities. So we're going to take a look at our patient's arms bilaterally. We're going to feel for the radial pulse. And remember not to use your thumb when you're checking the radial pulse because you could get your own pulse. So you're going to use these two fingers. You're going to grade the pulse on a 1+ to 4+ scale. So it should be about a +2, and that's normal. You're going to check for capillary refill. So you're going to press the fingertips in, and it should be an instant return of the color. It should be less than 3 seconds, but normally it's instant, and you're going to check that bilaterally as well. Also, while you're on the upper extremities, you're going to note the site of the IV. So we've got ours on the left side over here. You're going to look for any redness, swelling, or infiltrations. And then you're also going to note any fluids or medications that may be running at that time. You're going to note the integrity of them, and you're going to check for the 6 med rights, which are the right patient, the right drug, the right dose, the right route, the right time, and the right documentation. Now we're going to move on to the lower extremities. Be sure to expose your patient as little as possible throughout the assessment. So we're bringing the blankets up from the bottom here. And we're going to note the pedal pulses. And to do this, you feel this top bone on their foot and you kind of slide over. And there should be a vein there, and you just check the pulse on both sides. It should be a +1 to a +2. A +1 is normal because it's farther away from the heart. Now you're going to check the capillary refill bilaterally. Again, it should be instant or less than 3 seconds. You're also going to want to feel the legs for any edema. You're going to grade this on a +1 to +4 scale. +1 is normal, but ideally you'd want 0. So now we're going to check for some deep tendon reflexes. So we're going to grab our reflex hammer. We would do this bilaterally. I'm going to lift the leg, get my patient to relax. I'm going to find the groove between the patellar bone and the tibia. And once she's relaxed, I'm going to strike, and she should kick at about a +2. Again, we're rating that on a +1 to a +4 scale. If it was +3 or +4, that would be considered hyperactive, and that's a sign of preeclampsia. Another sign of preeclampsia we would find with hyperactivity with clonus. So to check for clonus, you're going to lift up the patient's leg, you're going to support under the ankle here, and you're going to rotate her foot to get it to relax. Once you feel that she's relaxed, you're going to snap the foot back, and if it bounces back against you or tries to rebound, that's called 1 beat of clonus, and you would count each beat. Sometimes that can become sustained and it could just continuously beat, and that's not a good sign. These are signs of preeclampsia. So ideally you want no beats at all, and you want a +2 reaction in the patellar. Next we're going to check for Homan sign, which this isn't checking for preeclampsia, but it's checking for deep vein thrombosis, so DVT. And in some hospitals, their policy does not allow you to check for Homan sign, so just make sure you check with your hospital or your clinical instructor. So to check for Homan sign, you are going to straighten the leg and dorsiflex this foot, so you're going to pull it forward. You're going to feel the back of their calf be warm, and they would be in excruciating pain, and they'd probably have a lot of swelling as well if there was positive Homan sign, so a positive sign for DVT. But a negative sign, they wouldn't be in any pain, and there would be no heat or redness or swelling whatsoever. Also, if your patient's laying in bed, you need to make sure that they have some TED hose or some SEDs on, and we can go over those in class. Now we're going to move on to the gastrointestinal. We're going to cover her legs back up, and we're going to pull down the gown and lift up her gown here. You want to lift up the gown because you want to see that belly. She did just have a baby, so you just want to make sure you're inspecting that area. You want to get a clear view of it. At this time, you're going to ask her, when was your last bowel movement? And it's normal for them to not have a bowel movement for a few days when they're in the hospital, but anything more than just a few days, you want to be concerned. So we're going to start by listening to the bowel sounds in all 4 quadrants. We're going to follow the GI tract, so we're going to start in the right lower quadrant. You're going to listen until you hear a bowel sound, and then you're going to move to the right upper quadrant, the left upper quadrant, and the left lower quadrant. Again, you should hear bowel sounds in all 4 quadrants. It should be normal active. Now you're going to palpate in the upper right quadrant, and this is where your liver would be. You don't want to palpate or you don't want to feel the liver because that would mean that it's enlarged, and you want to ask your patient if she's experiencing any pain or tenderness when you're feeling here. So if you felt the liver or if she had any pain, that would be a sign of preeclampsia, and we don't want that. So now we're going to check for the C-section incision site. So you're going to look for RETA. So RETA stands for redness, ecchymosis or bruising, edema or swelling, drainage, and approximation. So the redness, bruising, edema, and drainage, you don't want to see any of that, but you do want your sutures to be well approximated. Now we're going to go on to urinary. So we're going to ask our patient, are you having any trouble urinating? Are you urinating frequently? Because it is normal for a postpartum patient to be frequently urinating about 3,000 units per day. So if she is on a catheter still, we would check the catheter bag. We would note the color and the consistency of the drainage. It should be a straw pale yellow to a bright yellow in color. And we want to check the amount, and then we would drain it. And if there's any odor, that could be a sign of infection, so we also want to note any of that. We would also check the insertion site of the catheter. We want to make sure that we provide pericare and take care of the Foley catheter. Now we are going to go on to reproductive. So we're going to put on our gloves. And we're going to ask our patient, when is the last time you changed your pad? Your patient should be changing her pad pretty much every time she goes to the bathroom. If she's not, you just want to instruct her to do so. So we're going to let our patient know that we're going to expose her again, pull down her blankets, pull up her gown, and we're going to remove her panties. You may need to spread the legs here. And we're going to remove her pad and note the amount of lochia. So this would be considered a small amount of lochia. Lochia would be graded at about a scant, small, moderate to a heavy amount, and this is considered small. There are no clots, but some clots can be normal as long as they're smaller than the size of a golf ball. So we're noting the color, the amount, and if there are any clots there. We're going to leave that down there right now because we're going to massage the fundus, and some more lochia might be expelled in the process. So to find the fundus, we're going to take one hand. Since I'm over here on her left, I'm going to take my left hand and find the base and hold there, and take my right hand and sort of feel down from the top and find the top of that fundus. Once we've located it, we're just going to feel to make sure that it's firm. This fundus is not firm. It's a boggy fundus, so that just means it's a little too squishy for our liking. And so if you have a boggy fundus, you're going to want to massage it until it becomes firm. This is to prevent any hemorrhaging. So this process of massaging the fundus is not a pleasant one for your patient. She's going to be in a lot of pain, so just bear with her. And you're going to massage it until it becomes firm. So let's say that we're firm now. And you're going to note any lochia that has been expressed during the process. It should only be a scant amount of lochia. That's all you want to see. You're also going to note the location of your fundus. So your fundus should be midline with the umbilicus. It should also be below the umbilicus. So your fundus will descend at a rate of about 1 centimeter per day for every day after the first 24 hours of birth. If your fundus was over to the side or a little bit higher than normal, that might just mean that her bladder is full, so it's no cause for alarm. Now we are going to turn our patient over to get a look at her episiotomy laceration sites. For the sake of this tutorial, I'm going to move her towards me so that the camera can see. But in real life, I would move her away so that I could see. So from this angle, you're going to check if she has any hemorrhoids. Hemorrhoids are normal. She did just have a baby, so a couple hemorrhoids are okay as long as they're small. You're also going to note the episiotomy or laceration site. So the difference between those two is a laceration is a tear that happened on its own, and an episiotomy is a cut that the doctor made. And with an episiotomy, there will usually be stitches, so again, you're going to check for RETA. You're also going to check the epidural site if she had one at this time. You're going to note any redness, any major hematoma or bruising, and any skin breakdown that's going on there. And then you're going to turn your patient back over. You're going to change out her pad if she needs it, and then you can take your gloves off once you've cleaned her up and made sure that she's comfortable. So we're going to adjust our patient, make sure she gets comfortable. We're going to make sure she has a call light within reach. We're going to let her know that we would get her any pain medication that she needs. We would lower the bed and bring the side rails back up. And one very important thing that we want to remember at the end is to note the level of consciousness of the patient throughout the assessment. So once your patient has everything she needs, you can perform hand hygiene and document.